For the next probably half hour or so, we'll go through some challenging renal mass cases and kind of discuss some...
It's got to reboot, sorry.
Oh, just discuss some... how do you...
It's going to happen.
Oh.
Here we go.
Oh,
there we go.
Oh, okay. So we'll go through some cases and be kind of querying our faculty here what they would do in these situations and discuss some of the kind of the learning points surrounding these cases. So did you present a solitary kidney case already?
I did, but
okay.
let's see another one.
Okay.
They're exciting.
So we'll just go through as many cases we get through, and you know, obviously fielding questions along the way. So we encourage questions. So this is a 67-year-old male with a history of a nephrectomy for trauma at age 18. So it wasn't a cancer nephrectomy that he had, but he had a nephrectomy at age 18. Now he's 67. So you know, almost 50 years later. And his preoperative creatinine is 1.05, so he has good renal function for one kidney, of course, and a history of hypertension, otherwise healthy. And he has this 3.5 centimeter tumor, as you can see in his solitary kidney. So when you look at this scan, Jim, what are some of the things you're thinking about in a solitary kidney case like this? Is this something that you would approach off clamp, or what are you thinking about here?
No, I definitely would not do this. I mean, this tumor is a bit deeper than I'd be comfortable doing off clamp. I mean, the people that I'm trying to do off clamp are really cortical tumors. This is very much against the sinus, and I'm probably going to get a collecting system here. Mm-hmm. So, you know, this is still a cancer operation first and foremost. We've got to make sure we can see. So I'm probably going to, you know, this tumor is not in a good location for selective clamping as well. That's the other problem, is it's going to get contributions from both the anterior and posterior branch of the renal artery. So you're just going to have to, I think, in my hands, I would approach this as planning to do complete ischemia and be efficient.
And how much ischemia time do you think you can get away with on a solitary kidney?
Well, a 67-year-old male, you know, in a solitary kidney, you know, I think you could probably safely do it under 20 minutes and probably safe.
Okay. And that's very doable, under 20 minutes?
Yeah.
How do you feel about enucleation?
You know, I think in a kidney tumor that's against the major renal vessels, you're forced to do that. But a tumor like this, I'm going to try and minimize how much kidney tissue I take, but I'm not going to purposely try and go on the capsule. I'm really going to give myself, you know, the margin that I would normally give, and just stay as close to the kidney to the tumor as possible. But I'm not going to try and enucleate it.
What do you use as your cutoff between when you go retro versus trans?
Yeah, well, that's a very good question. So I tend to do lateral tumors retroperitoneally, and if the way I come in and actually is pretty much right on line with this tumor, so I would probably do this tumor retroperitoneally, and I pretty much do medial tumors and anterior tumors transperitoneally. So I use the lateral line as a cutoff, but I will tend to shift things a little more anterior just because of the angle that we're able to approach it.
So you would err on the side of retro versus erring on the side?
Yeah, I do, just because of, you know, and I probably, it's about 60-40 retro-trans, but it's close to 50-50 in a lot of cases.
Okay, great. So as you mentioned, this is you know, very doable within 15-20 minutes at most of ischemia. So he had a warm ischemia time. We did clamp the artery. He had a warm ischemia time of 14 minutes and 54 seconds. His post-op creatinine, post-op day 1, did bump a bit to 1.8, but then he came down by year 2. He was 1.22, so pretty much back to his baseline.
Absolutely.
So he had a little bit of loss of you know, immediate renal function, but recovered quite well. And you can see the pictures there. These are all 2-year scans, and you can see you know, obviously the vast majority of his kidneys doing well. And interestingly, on the bottom left-hand corner, you see how his defect goes all the way to the sinus fat, just kind of something you don't see very often on these scans.
Right.
But because his original tumor went all the way down, you know, you still see kind of this hiatus here, which is just kind of interesting in how it looked. So he did fine. So even with clamping, he did fine. And I think enucleation would be an option. Some people would do enucleation on a tumor like that and do it off clamp. You know, if you do get into that enucleation plane, usually it's relatively bloodless. But, you know, again, we did a traditional partial, and he did quite well. So here's a 62-year-old female. She had a nephrectomy in the past for a 7.9 centimeter RCC. Done somewhere else, you know, laparoscopically. And then now 3 years later, she presents with a 1.5 centimeter mass during surveillance for her original tumor. And her creat at this point with one kidney is 1.19. So what would you do in this situation?
Well,
is observation an option?
You know, it is. I mean, you could follow it, but the longer you follow this, the larger it's going to get probably, and then you're going to take probably more, so it's going to be a more challenging partial potentially as time goes on. So, I mean, she's 62, she's not 82, so she's going to live at least another 15 or 20 years, so you're not going to avoid dealing with this at some time. So my mind is to deal with this when it's at its smallest, and I think that's going to be now. So I would offer her a partial nephrectomy robotically. This looks more towards the lower pole anteriorly than the upper pole. So this is a tumor I would attempt to try and do off clamp. I do have a nice video I show at all my courses of a very similar case, 1.5 centimeter tumor in a solitary kidney in a woman, and we tried to do it off clamp, and we ended up losing 1,600 cc's of blood for a tumor that was completely cortical. I mean, it looked capsular. It looked so superficial. And then I always show the H&E of the tumor. There were these giant vessels at the base of the tumor, and I have no idea why.
Wow. And
we all have this story, and everybody I talk to has that story. So it's not us. I don't think it's this. We're not touching anything. So anyway,
it's, probably just some neovascular, probably from the tumor.
Yeah. So anyway, I would try and do this as a off clamp.
And is the fact that she had a contralateral renal cell carcinoma make you more convinced that this is likely a renal cell carcinoma?
Yes, it does. I mean, you could potentially biopsy this. I think if that would, but it's still you're going to run the same question. I mean, is this going to really? You're going to watch this, and are you comfortable? Your radiologists are really going to get you the tissue you need to make the diagnosis.
Okay, Lee, what do you think? Would you biopsy this?
I would offer it, but I probably wouldn't. I would actually probably consider observing it and seeing what it does, and seeing if it starts growing. Then I would probably go to the partial. What would you do?
Okay. Well, I'll tell you what we did.
Okay.
So we actually did a biopsy.
Okay.
So as I mentioned, the times that I do a biopsy are the patients that I don't want to operate on. And I see this tiny little tumor on a solitary kidney. I said, I really don't want to put you through surgery for this. So let's see, we'll do a biopsy. So we did a biopsy. It came back suggestive of a low-grade eosinophilic neoplasm. Nests are compatible with an oncocytoma. Definitive diagnosis not possible due to scarcity of tumor in the specimen. Repeat biopsy should be considered. So she said, look, I don't want a repeat biopsy. Just take it out. I had cancer on the other side. Take it out. So we did an off-clamp partial. Fortunately, it went well, and it did turn out to be an oncocytoma, amazingly. So maybe we should have done another biopsy.
So let me ask you this.
But she did fine.
I think a biopsy is an interesting question, because even if you came back with these oncocytic neoplasms, how often are you comfortable that that's an oncocytoma versus a chromophobe? Or?
Well, according to the literature, a biopsy, a renal mass biopsy, is diagnostic about 80% of the time. And then if you do a second biopsy on the remaining 20%, you'll get a diagnosis in about 80% of those. So after 2 biopsies, the vast majority of patients will have a definitive diagnosis. The question is, though, if a large number of those patients are, because the pre-test probability of cancer is so high in renal masses, if the majority of those are going to end up being cancers, now some of those patients had 2 biopsies plus partial nephrectomy, when probably a lot of them you would have known ahead of time were renal cell and could have just done a partial.
All right. So in retrospect, should you have done?
So,
what should you have done?
Yeah. In retrospect, obviously, had we done a second biopsy, it probably would have said oncocytoma. In retrospect, probably what we should have done is not a second biopsy. We just waited till it got bigger, and then the pathologist would have had a better time, more tissue to look at. Probably could have made the diagnosis more easily. So probably in retrospect, it's hard to be that smart at the time, but in retrospect, probably what you could have done is said, let's just watch it for 6 months, a year, 2 years. If it wasn't growing very much, if it gets big enough that you can get a better biopsy. But again, the fact that she had a contralateral renal cell made her nervous, and she didn't want to mess around.
Yeah, I just wonder. I would just say in retrospect, I think managing it the way you did was what I would have done, because this thing would have grown. She was never going to be comfortable. I mean, biopsies are not 100%, so there's always going to be this lingering question, especially with a history of renal cell carcinoma. The longer you wait for this tumor, the larger it's going to get, the less renal parenchyma you're going to be able to spare. So, I think she had the best possible outcome.
She did. She's happy. So, completely endophytic tumors, we may or may not have talked about these already a little bit today. But obviously, the challenge with these is that you can't see them from the surface, so you're relying on ultrasound. What are some of the considerations that you have when you have a completely endophytic tumor? What are some of the thoughts going through your mind in terms of how you're going to approach this, how you're going to attack this?
Yeah. So, I really rely on the intraoperative ultrasound during the case. Obviously, you have to have it. It's not even you need it for every case, but these cases you not only need it, you need to know how to use it, and that's the biggest issue, because
you got to be good at it.
You have to be good at it, and you don't want to become good at it on these cases. You want to become good at it on those easy cases that you've learned to use it on. So with your expertise, you're going to in these endophytic tumors, you're going to mark your margin out, and you have to go a bit wider on these tumors than you would on a regular tumor, because this is down in a hole. In order for you to see and get that out, you can't really just do a tunnel. You actually have to do more of a wedge, a circumferential wedge, and those are going to be, that means you're going to have to go a bit wider on your margin. So that's number one. Number two, you're going to have a complex reconstruction. You're going to have, you know, you might be, and I have cases just like this where I actually was suturing infundibulum, the renal pelvis back together, you know, because the upper and the lower pole were separated because of where this tumor was. So I wasn't just doing a calyceal closure, I was reconstructing the collecting system there because that's where this tumor was and that's what it required. At the deep margin, you know, we're going to try and do an enucleation. We're going to do a lot of blunt dissection at the deep margin. We're going to try and get, you know, stay on that pseudocapsule as kind of another technical point to try and stay and decrease the amount of reconstruction we can do. These are normally complete ischemia cases. There's no real role for selective or zero ischemia, so you're clamping the entire hilum.
I agree.
And so,
it's essential to have a bloodless field.
Absolutely.
Because you can get lost.
These are the hard cases. These are very, very difficult.
So here's an example of a gentleman, a 50-year-old guy. He's got a 5.1 centimeter completely endophytic lower pole tumor. That's the green here in this 3D reconstruction. He's 50 years old. He's a hypertensive. He's diabetic. His BMI is 44. His pre-op creatinine is 0.8. Could you make an argument in this situation for just doing a radical nephrectomy? Certainly when I was in training, when we saw tumors like this, we did a radical nephrectomy almost all the time.
Yeah. So
would you do a nephrectomy in this guy, or would you say, well, he's hypertensive, diabetic, he's relatively young?
Yeah, I would do a partial nephrectomy because I think it's a, you know, it can be done technically, and I think the downstream benefit is that this guy potentially is going to have more nephrons later into life, given his hypertension, diabetes. He's probably not going to lose a lot of weight, you know, with a BMI of 44 at age 50. So he's going to have a lot of conditions in the future where having as much kidney tissue as possible is going to be beneficial. The good news about polar intrarenal masses is you can approach them a bit differently than the central endophytic masses, and you know, so let's see what you did.
So Lee, any comments?
No,
anything differently you would do here?
I agree. I would do the partial.
So looking at this scan, what would be your planned approach in terms of where you would excise this?
Yeah, I mean, the good news here is that it's a little more towards the lower pole, and so that means that you don't have to really do this digging out in a hole, whereas these tumors, when they're really in the center of the kidney, those tend to be the most difficult. So I'm going to probably do a lower pole hemi right across the top of this. I'm going to take off that lower calyceal system with the tumor and then sew that defect, and he'll have half his kidney left when we're done.
Yeah, and that's, you know, a good point to make, is that sometimes when you look at the scan in one dimension, you don't quite appreciate how much normal kidney there is. You just see the tumor and you say, oh my gosh, it's a nephrectomy. But then when you look at all the different dimensions as we see here, you actually see that there's a good, at least a half of an upper pole that's salvageable here. And so that's exactly what we did. So on the left is the pre-op and then the post-op on the right. So again, when you look at the axial view, you can't even tell a partial was done. But then of course, when you look at the coronal, you see that the lower pole is gone. So we basically did a lower pole heminephrectomy. And because of course the tumor is not contributing to his renal function, his creatinine barely bumped post-op. He was 0.8 pre-op. At 1 week, he was 0.87. You know, warm ischemia time was just under 14 minutes.
Wonderful.
So he did great.
Would you have done selective control on that one?
You know, in his case, because he had normal renal function preoperatively and it's kind of an elective partial, I didn't. You know, we did complete ischemia because again, when you do a heminephrectomy, you've got some big vessels in there, and you're going to have multiple segmental arteries contributing to that defect. So again, my priority in those cases is just to have a, you know, ischemic field.
You know, I found in those polar nephrectomies, we have been able to do selective clamping. You can usually, in many cases, find the lower pole branches that are feeding, but the problem becomes the posterior renal artery, because the posterior renal artery tends to be the whole back side of the kidney, and so when you do that hemi, that becomes a problem. But we've gotten lucky in a couple cases where we were able to do those selectively. And you know, I don't know if it makes any difference or not, but a 14-minute warm ischemia time probably is not much different.
Yep. So let's talk about multiple tumors in the same kidney. So here's a 49-year-old male, again diabetic, hypertensive, BMI 43. It's Ohio. What can you do? Pre-op creatinine is normal.
You can move.
He's got 2 tumors in his left kidney. One is solid, one is predominantly cystic. So you see that cystic tumor on the left kidney. It has this kind of weird stuff at the base, kind of nodular looking stuff, a little bit suspicious, some calcifications on the edge. And then he's got this more upper pole, medial, solid tumor. So what are your thoughts in this case? What would be your plan?
Well, do we know I don't have all the views here, but I mean, was this an MRI or what? I mean, was anything looked for? Was there any fat that was looked at in this?
No, there was no fat in either one. There was a CT. This was followed up MRI because the cyst was suspicious.
Yeah.
No fat, just predominantly fluid, but also this kind of stuff here at the bottom.
Yeah. So I think you could probably. So there's this. This stuff enhances at the base, or is it just debris? Do they know?
Didn't look like it was enhancing.
Yeah. So it's really hard to know if this cyst is an issue or not. It's, you know, if the wall's not enhancing and it looks like there's no, I don't see any septations in there. I mean, this could just be a cyst that he bled into, and it might just be that.
But if you're coming after this upper pole tumor, would you go ahead and remove that?
You know, you could because what you see here is the plane it's a reasonably shallow tumor, and that's really going to help with regard to your ischemia time when you're doing this other tumor. This other tumor is upper pole. It's, you know, it's not too deep. It's small. So yes, I would probably approach doing both of these at the same time as a partial nephrectomy. Again, clamping the entire kidney, and be prepared to have the kidney very mobile so that you can go back and forth and be able to have good access around the entire.
So you would clamp the artery and then resect and reconstruct both on the same clamp?
Yeah, I would.
Retro?
No, trans. I mean, I don't have axial, really. I really have to see with the axial. With the coronal, it's hard for me to always predict which way trans or retro.
Yeah, so generally multiple tumors you will do retro.
Yeah, we've done multiple tumors retroperitoneally, but they've all been, you know, posterior based.
Yep.
Okay. Lee, would you do anything different here? Would you clamp the artery and do both of these on clamp, reconstruct both?
I would. I actually had a case with 3 tumors just like this.
Okay. So we did a little bit different. We did the smaller one off clamp, and then we did the larger one on clamp, but it was, because it was shallow, it was only 7 minutes of ischemia time. But the upper pole one that we did off clamp, we actually lost 600 cc's of blood.
See, I would have done the reverse, actually. I would have done.
In retrospect, I should have.
Yeah, because the way how shallow that was, I would have probably done the
I was afraid to pop it. I was worried it was a cystic RCC. I was afraid to pop it. That's why I clamped when I did it.
Yeah.
So it turned out that the upper pole was a 3.5 centimeter RCC. That was actually a benign cyst, just had some proteinaceous fluid in it. Right. But he did fine. His creatinine post-op was perfectly normal. Let's talk about hilar tumors. So here's a 62-year-old, this is my hospital attorney that we love to drain in. So he's got a 5 centimeter, it's an incidental renal mass, it's right at the hilum, posterior hilum, as you can see. So what are some of the thoughts that you have when you do a hilar tumor, particularly a larger hilar tumor? What are some of the ideas kind of going through your head, how you're going to prepare for this?
Right. Well, you know, what I like to do in these hilar tumors is I like to, first of all, I get complete vascular control. That means arteries and veins exposed, because when you're in the hilum, you're going to have larger vessels to deal with. We're not talking about sinuses. We're talking about branches now. Okay. So these are the cases where I will clamp the vein in most cases, because you know, you get a lot of venous backbleeding in those cases. But the thing that I think really sets hilar tumors apart from other tumors is that I can do a lot of this deep dissection between the tumor and their major vessels in that Gilvernay plane. I can do that well before any ischemia. I can get a lot of that deep dissection done. I can get the collecting system away from the tumor. I can do all that in preparation. And then all you really have is this parenchymal connection between the tumor all the way down to the sinus. And in fact, it's not a lot of surface area to be operating on in many cases.
Yeah, I think to illustrate that here on the screen, this plane right here, there's just a sinus fat plane here, and you can dissect that all the way as deeply as you can, and then really you're just cutting this part.
Right.
And of course it's a C shape, because we're looking at it in the axial view.
Right.
But it's going to be a C shape, so you're going to be cutting here and then all the way around like this, you know, above it and below it. But really, like you said, there's not a really big parenchymal defect when you're done. You just see basically the sinus fat in the middle and then this C-shape horseshoe kind of configuration of parenchyma. So yeah, I think that's a key factor for these hilar tumors, is to try to get that that plane as well as you can. At the very, very least, you have to get between the vessels and the tumor. You can't clamp and then try to do that part.
Right.
You know, get that done beforehand. It's an avascular plane. Sometimes there's little tiny branches of the vein that are coming off, and you can just bipolar those and take them.
Well, sometimes you'll see an artery branch going to it as well, which you can get beforehand. You know it's going right to the tumor. You can just clip that, and you've helped yourself a lot by doing that.
Yep. So other things you think about?
Did you use your deep suture on this one?
No, we didn't. But other considerations, Lee, when you see a tumor like this, are there other things that you're thinking about? So complete vascular control, kind of getting that plane, that hilar plane, done ahead of time.
To be honest with you, the concern is more about with your repair.
That's reconstruction. Yeah, agree. So that's the main challenge, is once you're done, you know, the reconstruction is a little bit more challenging because you don't want to knock off any major vessels. So this is just a picture from a paper that Kauk published about how to tackle these hilar tumors. But essentially, the picture that I liked here that he made was that once you're done resecting the hilar tumor, you end up with this kind of horseshoe defect. And again, you've got these big vessels coming in here. The hilar vessels are coming in the defect. So you have to be careful not to knock these off. So you don't want to have any sutures going across in this direction. Otherwise, you're basically ligating the vessels, and you'll lose a large portion of kidney. So the key is just to stay shallow and have your stitches go parallel to the vessels all the way around. And then again, you don't want to have any sutures going in this direction that might knock off any vessels deep in the kidney. So his warm ischemia time was a little bit longer, it's 23-29, but again, did very well. 9-month creatinine was perfectly normal. Again, when I was in training and we saw tumors like this, we said nephrectomy. But one of the reasons I showed this case is just to show that a partial nephrectomy is feasible, and actually you do end up saving a lot of kidney. So you can see what he had left over. Again, a big bite taken out of the posterior kidney here on the axial view, but on the coronal view you can see how much kidney he actually has left after the you know, 6 months of healing. So it is worth doing partials in these guys if you can. Let's talk about bilateral renal masses, always a challenge. So here's the sixth case, is a 60-year-old man. He has a history of CLL, and for years he's been getting chemo every so often for his CLL, but doing quite well with it. And he's got bilateral renal masses just found on CT scan for his CLL, and he's got this relatively large tumor here on the right side, a 5.2 centimeter mass. On the left side, he has a more exophytic 3.5 centimeter mass. So what would be your first step in this case, Lee? Would you consider a biopsy in this guy?
Probably not.
It's pretty convincing to be renal cell. So he was actually biopsied before he was sent to me, I think because somebody wanted to avoid operating on him, and they were both RCC. So now you got to do something. So Jim, what would you do in this situation, both in terms of how you would approach these tumors, but also would you stage them? Which would you do first? Which would you do second?
Right.
Would you do a nephrectomy on the right, partial on the left?
Right.
Which one first? Which one second?
Right. So I would do, my rule on bilateral tumors is to do the easiest one first. And the reason for doing the easiest one first is that if you start doing this right-sided tumor being central, and that becomes a nephrectomy, all of a sudden you're doing a solitary kidney on the left. No matter how simple that is, that's still a much more higher pressure case.
Sure.
So your best option is to do the simplest tumor first with the best chance of doing a partial nephrectomy. Let that kidney heal up. So I would stage these. You know, give ourselves, you know, it can be 6 weeks or something in between, whatever, I don't know what the magic time is, but probably do the left one side first, 6 weeks later or 2 months later, go back and then try and do a partial on the right. I would try and do partials on both. With bilateral renal masses, there's a chance he's going to have tumors in the future. So I would definitely try and do partials on both.
Yeah, another consideration too in his case not to do a right nephrectomy was because of this chemo reliance. You know, he was getting chemo every so often. We wanted to maintain his renal function as much as possible.
Right.
So we did do bilateral. We staged it. We actually had 2 months between. So we actually did the right one first. Maybe I was wrong, but I kind of was thinking the opposite. I was thinking, gosh, if I end up having to do a nephrectomy, I'd rather know that before I do the left side so that I know how critical the left side is, because maybe I'll do it off clamp or something if I did a nephrectomy on the right. So I actually did the hard one first. Fortunately, was able to do a partial. And then here on the bottom right-hand side of the screen, you see what he was left with. So he had this large, very central tumor, but there was still a lot of good kidney above and a lot of good kidney below, and you can see on the excretion phase that that's functioning kidney. It's just got this big scar in the middle where this tumor used to be. So we did the right one first. After the right partial, his creatinine was only 0.83, and then after, pre-op was 0.83. After the first partial, he was only 1.04. The warm ischemia time was about 21 minutes, 51 seconds. After the second partial, he bumped a little bit more up to 1.73. I don't know if that means we didn't wait long enough and the other kidney hadn't recovered enough, because you would have expected him to have bumped more after the big partial on the right. But even with a short warm ischemia time on the left side, he bumped a little bit more, but he was still 1.73 after the second partial, and he got back to normal eventually.
I think when you measure these things too, it makes a big difference. I mean, you know, we've seen improvement in creatinines down the road with these bilateral tumors. I don't know why, but you know, if you measure them at 6 months and a year later, we've seen some improvement. So.
Yeah, in retrospect, though, maybe I would have waited a little bit longer than 2 months to let that, just because of the size of the initial resection and the length of the ischemia time. So here, let's talk a little bit about elderly patients. I mentioned this a little bit before in terms of not making these one of your first cases, the frail old patient. So this is a 73-year-old, he's diabetic, he's a hypertensive, he's had a prostatectomy for prostate cancer in the past and a history of kidney stones. And he's got a 5.3 centimeter completely endophytic renal mass, as you can see here on the left side. So in terms of life expectancy, what are you estimating for this guy? Diabetic, hypertensive, 73 years old, not the most functional guy. What are you thinking here? Are you thinking nephrectomy? Are you thinking observation? Are you thinking biopsy, partial?
Well, I'd have to, get a sense of his. I mean, diabetic, hypertension, and stones is everybody in our practice. So if we did nephrectomies on all those people, we do them on everybody, So I guess the other thing is, is his prostate cancer...
It's under control.
Under control?
Yep.
Then, this guy probably has 10, 15 years of life. I mean, unless he's got significant coronary artery disease, if that's not on the list. If that's on the list, then that probably changes my approach. But...
I think most people, 73, diabetic, hypertensive, probably most of them have coronary artery disease.
Well, but
whether occult or
whether it's significant or not, whether they've had symptoms or ischemia, that's really the issue. So I would say in this case, what's his creatinine?
Normal.
Normal creatinine.
Yep.
So I mean, I think it's dealer's choice in this case. I think you could do a nephrectomy. I don't think there's anything wrong with doing a nephrectomy. I think he would probably, for the rest of his life, be off dialysis. Given. If he's got normal renal function, and he's probably not going to live to be 90. So, I think he'll probably be fine with a radical nephrectomy.
Okay, Lee, would you do anything differently?
I would do a partial though.
Yeah, I would give him a choice.
Yeah, I would
You'd be fine with a nephrectomy, but you would still.
Yeah, I would still do a partial. I'd still offer him a partial. I think a radical nephrectomy is not a wrong answer, but I think technically we will give him a negative margin. We will have a reasonable ischemia time, and he will have functioning renal parenchyma when we're done.
Okay. Let me ask you this. What do you do about the patient with stents?
Coronary stents?
Yeah, and they're on Plavix.
So, it's a discussion with the cardiologists, and, if their stents are a year or older, typically they'll let them come off the Plavix,
Right.
but they want them to stay on the aspirin,
But
so
those
I'll keep
1 year
them on
ones.
aspirin. It's the ones that are less than that, I'll try to just push the surgery out.
Okay.
So if it's a prostate cancer, obviously, and it's a low-risk surgery, we'll try to push it out. If it's a small tumor, we'll just observe it for a while till he can come off the Plavix. I don't like doing partials on Plavix. That scares me.
Yeah.
I've done it before, but I'm not happy about it. I'm willing to do it on aspirin, though. If they have stents, though, no matter how old they are, and they take Plavix, aspirin, or even if they just take aspirin, I do their surgeries on aspirin because there is a phenomenon of rebound hypercoagulability on these patients who have stents and have been on anticoagulation for a long time. If you stop their aspirin cold turkey, and they're at a higher risk, apparently, according to the literature, for clotting off their stents. So I will do their surgeries on aspirin, but I try to push their surgeries out until I can take them off Plavix, if
So
possible.
this guy you'd wait if he had a stent placed 3 weeks ago?
I'll show you what I did on this guy, because it may be a little bit surprising. But as I mentioned, the guys that I biopsy are the ones that I don't want to operate on. So this guy was not really the most functional 73-year-old. He looked his stated age, maybe even older. So we actually decided to do a biopsy on him, and it came back as an oncocytoma. So in his case, I said, well, I wasn't as optimistic about his life expectancy. So I told him we would just observe this and keep an eye on it. If it's not growing very quickly, we would leave it alone. If it looks like it's growing, of course, we could always intervene. But he elected surveillance.
So how often are you going to follow him?
Initially, I'd probably follow him about every 6-month intervals initially. After a year, maybe a year and a half, if it hasn't grown much, probably go out.
But why follow him at all? Why him just at all now?
Because if it's growing quickly and it gets to the point that it's going to be symptomatic, he may end up eventually needing.
I mean, symptomatic in what way?
I've taken out an oncocytoma that big, so I don't want to let it get that big.
Well, I understand, but I mean, these patients can live with these large tumors for a long time.
Yep.
I guess the question is, if it's really an oncocytoma, unless you're going to do something.
Yeah, probably not going to. I didn't want to, so obviously that's why I didn't.
So I don't know why you would image them at all then.
Yeah, maybe not. Yeah, maybe you don't have to.
My problem with these tumors is that, and this is a different case, but we have these same oncocytomas in 60-year-old women who are going to live another 20 or 30 years.
Yeah.
And a 5-centimeter oncocytoma, eventually you're going to deal with, And the way you're going to deal with it, if you leave it alone, is a nephrectomy. I mean, that's what you're going to do.
If you wait too long, yes.
I mean, 5 centimeters is starting to get to be too long. You know what I'm saying? We see some of these at that point, and you could take out these larger ones. But I guess my point is, the longer you wait, the less of a partial nephrectomy you can do. So that's that's where I see biopsy gets us into a kind of a decision making that is can sometimes be challenging, because we're now faced with, oh, here's a 6-centimeter oncocytoma. It's not a cancer, so what do we do? Go, well, it's not a cancer, but it's going to continue to grow.
Yeah, I think maybe that's the reason to follow it, is just to get a sense for how quickly it's going to grow. Because if it's going to grow very slowly and it's going to be 10 years before it causes trouble.
Well, we know it's going to grow. These grow.
They will. They will.
And the more that grows, the more difficult your partial nephrectomy, and the more likely the patient's going to get a radical nephrectomy.
Yeah, and again, I think in that guy, if he does,
so that's why I vote for not necessarily doing surveillance in these patients if eventually you're going to have to do something.
Yeah, you're probably right. It's a good point.
Yeah.
So here's a case that I showed just because it has a surprise at the end. So this is a 70-year-old man now. He's got Parkinson's disease, deep brain stimulator, relatively functional with his stimulator on. Walks with a walker though. Coronary artery disease, BMI of 43. He's got a 9.7 centimeter lower pole mass in the left kidney, as you see, and his pre-op creatinine is 1.36. Is this the guy, because his functional status is not that great, he walks with a walker, he's obviously morbidly obese, is this the guy that you would say, you know what, you got a 9.7 centimeter mass, you need a nephrectomy?
Yeah, I mean, I think that's what most people would do. I think that's very reasonable. I think the larger these tumors get, especially in men, the more likely there's T3 disease, and T3 disease potentially may not hurt this patient given how sick he is, but it's going to hurt some patients.
Lee, what would you think? Anything different?
Now I'd probably just do a nephrectomy.
Nephrectomy? Okay. So the clincher in this case, or the surprise, was that I decided before doing a nephrectomy that I would do a renal scan just to find out what kind of function he has. It turns out his function, his split function, was only 30% on the right. So if we did a nephrectomy, his pre-op creatinine is 1.36, only 30% function coming from the right kidney, the good kidney. So that made me nervous.
What made you do that in this case?
His kidneys looked sickly. So just, you can't tell from this picture, but just when you scanned through, they were kind of lumpy, bumpy, and kind of gave you that feeling that something's not right. So that's why we did the renal scan, and you know, that was the surprise here. So we ended up actually doing a partial nephrectomy despite the fact that it was almost 10 centimeters, almost 22 minutes of warm ischemia time, but he had no complications, went home post-op day 1. He only bumped from 1.3 to 1.58, so he actually did quite well, thank God. This is a patient, 66 years old, another large tumor case, hypertension, thyroidectomy, BMI of 36. He has an 11.8 centimeter mass. This was found on staging for rectal cancer. So it's an incidental finding on staging for rectal cancer. And they were actually planning to give him neoadjuvant chemo prior to his APR. Then they saw this mass and they sent him to me and said, we want you to deal with this first. So his pre-op creatinine is 0.86, but here you see the tumor. And again, this is a guy who needs chemo for his rectal cancer. So despite an 11.8 centimeter mass, would you consider a partial nephrectomy in this guy?
So
what chemo do they want to use?
I don't recall.
But was it something that would have been limited by his renal function?
I don't know. I'm not sure, to be honest with you. But
yeah, I mean, it's hard to say in these images that you can even do a partial. I mean, I really can't see it.
If you look on the right, though, you can see that this is predominantly a lower pole tumor.
Yeah.
So it did continue pretty much all the way down to his ASIS. It was quite large, but there was a good amount of lower kidney.
If you look at the image on the left, it looks like he has no kidney left other than, a little nubbin. But you're saying there's more kidney there?
Oh, yeah. I mean, that was just more anterior.
Yeah, yeah.
But as you went posterior, you kind of see this normal appearing, portion of kidney up here.
Yeah.
So is there a size cutoff for partial nephrectomy? Do you have a size cutoff? Is it more the location, the depth, these kind of factors?
It's really location and the depth. I've done a 13 centimeter tumor as a partial, and it was fine, but it was pretty much an upper pole tumor.
Lee, do you have a size cutoff for partial
I don't,
nephrectomy?
but I would probably do a nephrectomy. I probably wouldn't. I'm sure you're going to tell us you did a partial, but
we did. Again, so here's a better view here to show how much normal kidney he had. So again, and depending on the cuts, this actually went all the way down to about here. That's how it got to 11.8. But we did a renal scan pre-op, and his split function was pretty much 50-50, so I think he would have been fine with a nephrectomy. But we did do a partial, just again because of this question mark of chemo, and had a short warm ischemia time, about 15 minutes. His post-op creatinine was only 1.2. It was T3A, not surprising based on the size, but negative margins, and he did well.
Would you have biopsied it? Any concern about it being
metastatic rectal cancer?
Yeah.
I don't think it would have made a difference, honestly, because even if it was metastatic rectal cancer, it would have been the bulk of his tumor. So, the guy's going to get systemic therapy anyway. And
well, they would have given him chemo first before your nephrectomy if it was metastatic.
That would have been a hard partial then.
Well, I know,
or a hard nephrectomy.
But they would have done.
They probably would have done the chemo first.
With the functioning kidney, he still has left.
I think a post-chemo nephrectomy in that setting or partial nephrectomy would have been much harder.
And his thyroid was not for cancer? His thyroid?
So here's a situation, salvage after percutaneous therapy, so that we can get on the subject a little bit about percutaneous therapy as an option for renal masses. So this is a 45-year-old healthy male, had a percutaneous renal cryo at an outside hospital. This is the picture of the tumor originally when he was diagnosed. Unfortunately, he had a hematoma and genitofemoral nerve palsy after his procedure, so it just goes to the idea that percutaneous therapy is not completely benign, of course, there's complications. And he comes to me 3 years later because of a recurrence. So this kind of brings the question of when is ablation a good option or a bad option. So in 2005, you can see his tumor. They watched it until 2007. It grew. They decided in 2007 to do the cryo. And then after the cryo in 2008, looks like a pretty good result. And then 3 years later, he comes to see me, and now you see this recurrent tumor. So the black here is the original tumor. It's dead, but at the edge, he grew a new tumor. So what are you thinking in this situation in terms of treatment options? Start with you, Jim.
Well,
do you offer percutaneous therapy, and who do you offer it to? What kind of situations?
Well, I really offer it to patients who are very debilitated with, marginal renal function, who I think need the least impact to their overall renal function. So these are usually elderly patients with multiple medical comorbidities who have marginal renal function, usually a creatinine above 1.8, usually in the above 2 range. And I think that they're going to take the least impact from a percutaneous ablation, and it's usually done, at least in our institution, it's usually done as a percutaneous radiofrequency ablation.
So a 45-year-old healthy guy?
I would not offer a 45-year-old male an ablative procedure. I just think, the best follow-up data we have is 8 years, and 8 years for a 45-year-old is not enough time to know what this means. So that's my first problem with ablative therapy, is that it's not enough follow-up time. My second problem with ablation is that the patients that I offer it in have very poor renal function, and they can't get IV contrast, and they can't get gadolinium. So I don't know how to follow these patients who have really poor renal function after ablative therapies. How do you know success? How do you measure success? And then how do you know if somebody has a recurrence like this, which can occur? So that's my other problem in general with ablation, is that the people that really get these in my hands are really difficult to follow.
Yeah, in my personal practice, the patients that I've sent for ablations are typically the patients that I want to do surveillance, but the patient doesn't want surveillance. So, okay, well, here's something in between. But I agree with you. In the vast majority of patients, especially the younger, healthier patients, partial nephrectomy is kind of my default. Lee, do you disagree?
I've done it on one patient, a 45. This may be him. I've done it on one. I've done it on one patient who came, who was on active surveillance and actually did not want surgery, and came looking for an ablation. And we did a study actually looking at all comers that we were going to offer it in patients and follow them. We had 2 recurrences in those patients. But interestingly, we retreated them with the repeat cryos. And of the ones that we've had to retreat, they did fine. There's this whole idea of, well, if the morbidity of one cryo is pretty minimal, as long as you're repeating the cryo at a second or even a tertiary time to ablate it, is the overall survival change. And this is what we were debating. And but I have offered it in one young patient, and
So this guy's now 48 with a recurrence. Didn't have a great experience the first time because he had this bleed and this genitofemoral nerve palsy. Would you offer him a second cryo, or would you do a partial in this case?
I'd offer him partial.
Partial. Would you do the same? Partial. So challenges that you're going to encounter when you do a partial?
I think this is the most challenging partial you can do. These are usually extremely stuck, at least in my experience. This patient was treated twice. It's very, very stuck all over, and you end up having to take more tissue than obviously a regular partial.
That's exactly what we found. So it was very hard to find. The fat around it was inseparable from the area of the tumor. So we purely relied. It was like a complete endophytic tumor. We relied completely on the ultrasound. So a very difficult salvage. Fortunately, it was small though, and this is what the specimen looked like. But he did very well, no complications. He's now 4 years out with no recurrences. So sometimes patients will come to you with poor imaging studies. And so the question is, what is your routine in these kind of situations? Here's an example of a 57-year-old healthy female. She's depressed. She came into the hospital for renal failure from anorexia, so she just hadn't been eating or drinking for days and days, and she came in with renal failure. So they did a renal ultrasound just because her creatinine was so high. It was up to 6. And then after they hydrated her, admitted her, they did this renal ultrasound. They saw a mass on the ultrasound, incidental finding, sent her for an MRI because they couldn't do a CT. So here's her ultrasound, and this is where they're pointing to the mass on the ultrasound. And then because of this abnormal ultrasound, they sent her for an MRI. Again, her creatinine is quite high. So this is what her scan looks like. So what are your thoughts on this lady? Is this imaging concerning to you? Are you convinced about this?
I'm not convinced.
Obviously not,
based
because
on
I'm
this imaging.
asking, right?
Right. No, I'm not convinced. I would let this woman get her creatinine down to normal. She should be able to get her, get hydrated, and unless she has, chronic renal failure, she should be able to get come back and get a better scan, a better quality scan after her creatinine normalizes.
Lee, thoughts?
Yeah, I'd see. Hopefully, her creatinine improves. The question
It came back to normal.
Okay, so then it's less a question. The question really is then what to do in this patient where it doesn't come back
Yeah.
to normal, and those are the real dilemmas.
Well, that's where a biopsy actually may be helpful. I think if an ultrasound is all you can get, they could biopsy this mass. If it's truly a solid mass, which you can see on ultrasound, that's where a biopsy may actually be helpful.
The other thing is, and we actually looked at this, is you can do CT scan in patients with a significant compromised renal function with contrast, just recognizing they may need about 3 different, they may need dialysis procedurally for about 3 times, but it's almost 100% of the time reversible injury if they get it after a CAT scan. So it's just, because we at one point we were seeming to see a run of these of you're stuck in what to do.
You need good imaging, and you just bite the bullet.
Yeah.
So the reason I show this is because I have a rule, and that is that if the tumor is hard to figure out on preoperative imaging, we won't take them to the OR. We've got to be able to see the tumor. And if I'm suspicious on a CT or an MRI and we can't really tell where the tumor is, then I'll send them for an ultrasound, because ultrasound is what I'm going to use intraoperatively. And if I can't see on an ultrasound, I'm not operating on that patient until I have good imaging. So in this case, there looks like there's a mass there, and that's how it was read by the radiologist, but just the edges don't look right. It's not really that convincing.
It looks like volume averaging to me. I mean, I don't really see it.
Yeah, it's not
Right.
a really convincing
Right.
picture. So again, we didn't want to operate on this lady. So we actually waited. We waited a couple months. Her creatinine came down to 1.2. We did another scan, another MRI, and it was perfectly normal.
Yeah.
There was no tumor there at all. So it was just kind of a little hump in the kidney. So again, the rule of thumb is don't take a patient to the OR until you know where the tumor is. And if it's not well defined on CT or MRI, you can get an ultrasound, because that's what you're going to use intraoperatively.
There's a question about contrast ultrasounds. You ever using it?
I haven't. No.
How about
Have you?
bubbles?
I think kind of a corollary to that is that some of these small renal masses you do see on in the kidney, they're endophytic. I will get an ultrasound on them pre-surgery just to make sure somebody can see with ultrasound, because I've been unpleasantly surprised during surgery trying to find these masses with ultrasound and not be able to see them, because they look very isoechoic sometimes to the normal kidney parenchyma, and I think it's really good to get an ultrasound on those patients beforehand.
All right, so this will be our last case. We're going to talk about the complex cystic mass. So this is a 44-year-old female. She had some flank pain, went to the emergency room, had a CT, shows a complex right cystic mass. So her kidney was, because of the size of this thing, it was about a little over 9 centimeters. The kidney was kind of turned on the side. So on the axial view, it actually looks like a coronal kidney because the kidney was turned. But you can see she has this large cyst in the lower pole of the kidney. It's kind of occupying the entire lower pole. But then it had this little kind of solid appearing area, as you can see here, inside of the cyst. So what are your thoughts in this situation? Again, she's 45 years old. Is this a nephrectomy? Is this a partial? Is this an observation, biopsy? Lee, let's start with you.
I'm worried about that thing inside the bigger cyst. So I would probably consider, I wouldn't biopsy it. I would probably consider.
Do you ever biopsy a cystic mass?
No.
Ever do cyst aspiration for cytology?
Not for cancer. The only time I've done cyst aspiration.
I don't either. It never helps. So I never do it. I'm always worried about popping the cyst too and getting leakage and whatever. Maybe I'm crazy, but I never do biopsies of cystic masses. So what would you do in this case? Nephrectomy, partial nephrectomy? What would be your thought?
You know, from that one, I couldn't tell, but up on the top, it looks like you could do a partial on this. It seems. The other question, which I would ask myself, but I probably wouldn't have the guts to do it, is that outer cyst truly look like a simple cyst, and is the center thing really just the concerning lesion? But I would probably do a partial nephrectomy.
And I'm always nervous when I do partial nephrectomies for cystic masses. I'm always worried about popping the cyst. It's my biggest concern. So my discussion with her preoperatively was that, you know, if we get in there and we feel like we can do a partial nephrectomy safely without popping the cyst, we'll do a partial nephrectomy. If we can't, we can, you know, we would progress to a nephrectomy just for the purposes of safety. Again, it's elective. She's got normal renal function, normal kidney on the other side.
You're going to show it?
if the video works.
Okay.
I don't know.
Well, I would say one thing that's helpful for these cystic masses is, this one tumor I did that was 13 centimeters was actually a complex cystic lesion. We thought it was like a multicystic nephroma. And I actually left the cyst in place, and I operated the normal kidney away from the cyst, left it, didn't even touch the cyst, and actually did a heminephrectomy after I got vascular control to everything that was going to the cyst, and then I just moved the lower pole away from the upper pole and left it until I did, you know, all the closure, and then at the end I came and got the cyst out, and it worked quite well.
So that way all the fat around the cyst keeps you from popping it.
That's right, and you're not handling it. You're not handling it during that critical part, so it's almost like a pheochromocytoma mindset. You know, you're trying to operate away from that. The other thing with a cystic tumor is you need a thicker margin of normal renal parenchyma, because that's where you're going to be putting your pressure. So when you saw Ronney today putting his hand up on the tumor, cystins down, well, when you do that against a cystic tumor, that's a problem. Okay, so you need a thicker rind of parenchyma to keep yourself out of trouble in that regard.
Yeah, that's exactly what we did. As you can see here, we've got a good rim of parenchyma around the edges. This is kind of the base. You can see the cyst went right up to the sinus fat, so we really had to enucleate that deepest portion that was against the sinus. And amazingly, this did turn out to be a cystic renal cell carcinoma. Ischemia time was just under 20 minutes, minimal blood loss. Her postoperative creatinine was 0.95, amazingly, so she barely budged because there was so little normal kidney removed, of course. And she went home post-op day 1, no complications. I saw her back. She's about 4 years out without a recurrence.
Yeah, perfect.
So again, you know, when I was in training, we would look at something like this and say nephrectomy 99% of the time. But again, if you look at the amount of kidney that we saved on her, even 6 months postoperatively, you see that we saved about a half a kidney. She could probably live on that if something happened to her other kidney.
Yeah. She has more than half a kidney there. I mean, it's, you know, she's got a lot of kidney there.
That's a good case.
Yeah.
So we'll conclude there. Maybe if there's any burning questions, we can take them. Otherwise, I really want to thank Lee and Jim, both of you. I'd like to thank SurgiQuest, of course, Gary, and Global Cast MD for doing such a fantastic job, and obviously everyone for watching. And again, we plan, of course, to make a recording from this so people can watch it after the fact if they want to get you know, tips in the future. But hopefully this has been very valuable for you as the audience, and hopefully you can take some of these tips and tricks and use them in your partial nephrectomy cases coming up. So are there any burning questions that we need to take? Otherwise, we'll wrap it up. Okay, we made perfect timing. So thanks again, Jim.
Thanks, Ronney.
Lee, thank you very much.
Thank you.
All right. Thank you for watching.